All right, so we are recording now. I have only access to one of you on my gallery view. So if something comes up, you need me to stop, just unmute, say, "Hi, James, I got a question," or something like that. Or Dylan can kind of just do this because he's the only one I'm seeing on the screen, and that'll be my indication to pause and kind of maybe answer somebody's questions. This topic was one that I think was asked for quite a bit. I maybe remember last summer we did a survey and kind of asked people what they were interested in. And this one came up in about 30–40% of the surveys. So, lumbar classification, treatment, and the evidence. And what we're going to look at today is information from APTA as well as JOSPT and their CPGs, a lot of letters there, their CPG aligned interventions, and how we can start to use this information to move away from kind of our classic um, image-based, physician-based diagnosis of something like degenerative disc disease to more of a symptom-based category and classification, and how then we could use that to then move into treatment.
Do you have to save through always, or can I just use it?
So if we start with kind of looking at the why, we just talked about that, but then what we're going to actually talk about, radiculopathy, we'll look at somatic referral, we'll look at movement coordination, impairments. We'll look at this in kind of a single slide. We'll discuss kind of the pieces, and then at the very end, we'll give you kind of a printable takeaway that you can use in the clinic. And so, from just a real quick kind of why do we share? Why do we classify? Why do we kind of go from what the doctor says diagnosis into more of a kind of a classification by symptoms? And this is really because the classification helps us understand intervention. It helps us understand what the evidence says, and not just, hey, we're going to treat you with kind of our standard low back protocol. I was kind of speaking with a student that came back to see us this past week, and he was mentioning that he was at a clinic and he got several from his kind of therapist there, and that they had a bunch of knee patients, and they standard printout for knee exercises. And that's what they were giving the patient, or they got a standard printout for low back pain. And that's what they were giving the patients rather than really using any kind of evidence or patient specific treatment protocol. They were just kind of given a blank sheet or a sheet that had everything filled out, and they were told to go through that. So really what we're trying to look at doing are matching the impairments to the interventions. We're trying to use that as a prognosis prediction rule
Is that one of the different breath from
to
here?
monitor and then kind of classify how they're progressing.
And that was it. So for those,
All right. So what we're going to see when we look at the summary of recommendations is you'll see A, B, C, D as kind of a grading system, and then the corresponding strong all the way down to weak evidence and conflicting evidence. In other words, they would recommend against that for a level D. So this is just a quick screenshot from the actual summary of recommendations. You can see that it's got categories on there: acute low back pain, acute low back pain with leg pain, or even manual other directed therapies for chronic low back pain. And so this is what you'll see, and this is probably the best place to start with a CPG if you're not familiar with them or haven't looked at them, is to just go to the summary of recommendations page and read through that. It does help kind of introduce the material to you. And then as you go further into the actual CPG, the guideline, you'll get a little bit more definition in how they came up with these grades. Alrighty, looking at the level of evidence that they use, this is kind of how they came up with the grades. Level one, you might be familiar with as kind of evidence obtained from a diagnostic study or what we call a randomized control. And then all the way down to case studies will be a level four. Not very good evidence, just kind of specific one. And then even expert opinion. So, somebody that you respect tells you something that's honestly kind of not very high on this chart. Although you might find that it's helpful, there's no evidence to put behind it other than just clinical experience. All right. So our first classification, low back pain, radiculopathy, or low back pain with radiating pain. And this is defined as typical pain that goes below the knee and has kind of a cramping or a paresthesia to it, a numbness. It often involves a tingle or kind of an electric quality that will go below the knee, maybe often involves the foot, typically from either a stenosis or a disc kind of pressing on that nerve. Gives you a little bit of information from the demographics, age 50. It's typically a little bit more of a gradual onset versus the younger age. It's a little bit more of a maybe an annular tear or some injury that creates an immediate onset of pain. Okay, so that's radiculopathy, kind of the demographics, the symptoms, and then some tests that we can use for those stenosis people. You might see a treadmill test or a bike test, what we call maybe the walking screens. If you're not familiar with them, you can do a little bit of research on your own, but real quickly, a treadmill, for instance, if we're thinking stenosis, treadmill test would be somebody kind of standing upright. They walk, they get the symptoms. You would then have them flex forward on the treadmill using their arms to support themselves, continue walking and see if the symptoms improve. That would be more for the kind of stenotic involvement. And then if you are maybe doing something with, say, for instance, radiculopathy, you might use the straight leg raise test, the lower limb tension test, maybe confirm that with some dermatome, myotome, reflex screening, what we might call the neuro screen. Okay. But I'm going to stop right here and I'm going to kind of come back to the group as a whole and ask, what interventions do we currently use for our radiculopathy patients? If we get somebody that is suffering from leg pain, below the knee, what are we really starting to do with these folks? And it doesn't matter if it's traction, doesn't matter if it's soft tissue. I'm just looking for a little bit of discussion on what do we actually start to do with these people? All right, I'm going to start to call on folks. Let's see here. How about Chase? They're in Plano. Give me a shout. What do you like to do with your folks that come in and maybe they've got some leg pain and it's coming from their lower back? What do you like to do with those folks?
Usually I do some soft tissue, depending on how intense it is. we do some like gentle stretching, and if it's more radicular pain, we might try some nerve glides um, versus tension testing and just kind of see how they tolerate it. And based on their tolerance, we modify from there and go more out.
Okay. So what I heard was it was a little difficult to hear, but what I heard was soft tissue work, maybe a little bit of stretching, maybe a little exercise, just based on tolerance.
Yeah.
Yep. Okay. Let's go down to Mr. Jason Hogel there. What do you got? What do you got for us? What do you do for folks that have low back pain with leg pain or radiculopathy?
Really, any sort of thing just to start down regulating that nerve, whether that be nerve glides or sometimes even some dry needling just to get everything to calm down.
Okay. All right. So kind of working on getting things to calm down, maybe use a little dry needling, anything that might kind of help. Um, I've got okay, I just saw you there on the chat. Joint lobes, UPHA, saw that. Okay. All right, so let's go back to, and all good suggestions, but what do you think the evidence says? Do you think the evidence would back you up on what we just kind of heard from our colleagues and talk about? And I didn't point anybody out on purpose to kind of do a gotcha moment. But if we looked at what does the evidence show us for what we just talked about, I'm going to share the CPG if I can. All right, let me go back and pull it up here. Sorry for the pause. I had it pulled up and it seems to have disappeared, so I'm going back to look at it, get it here. All right, so now we can come back, we can take a look at this real quick. All right, so hopefully you are seeing the screen now with kind of the actual summary of recommendations on there. I see Round Rock and Quarry Lake. Somebody just give me a thumbs up that you're seeing the share. Okay, good. All right, so we're going to look at exercises here. The first category for acute low back pain, second category, acute low back pain with leg pain. All right, so here we go. Physical therapist, this is a level B. May use exercise training interventions, trunk strengthening, endurance strengthening to reduce pain and disability for patients with acute low back pain. All right. We keep going. Here we've got uh, classification systems for acute low back pain. It's good to use those. We may use those. Physical therapists can use for acute low back pain. There's the manual therapy in there for acute low back pain. And then we start to kind of move into some things like chronic low back pain and so forth. And then you get into kind of actual how they got there. I'm going to scroll down until I find low back pain with leg pain. All right. So here we start to look at exercise for this is for acute low back pain. Exercise gets an A grade. Centralization and directional preference gets an A grade. It's level 2 evidence for acute exercise. Flexion-based exercises is get a grade of C. telling you that, okay, probably not the best thing to flex somebody with an acute kind of low back pain or leg problems, right? And then here we get into now specific with leg pain. Muscle strengthening is a level 2. That means the evidence is pretty strong. Specific trunk muscle activation, level 2 in the literature. And then exercise training gets a B for overall with low back pain and leg pain. And so that's kind of how you would want to use that if you're looking for exercise training. If we go down to the next one and look for manual therapy, see, it takes exercise and it goes through kind of chronic pain. And so you got to keep scrolling until you find what you're looking for. Manual therapy, other directed therapies. And now you're going to go through and look at overall recommendations. Manual therapy gets an A, nerve mobilization gets a C, traction gets a D, saying that not very preliminary evidence, but that the benefit is intermittent at best. All right, let's look at thrust and non-thrust mobilization. Actually has a level 1 evidence behind it. That's going to be for acute low back pain, as long as they don't have any leg pain. So you have to kind of start to tease out some of these. Let's see if we can find our specific acute low back pain with leg pain. There's a little bit of evidence on dry needling. All right. So overall recommendations 2021, physical therapists should use thrust or non-thrust mobilization to reduce pain and disability in patients with chronic back pain. Well, that's not what we're looking for. They may use it for chronic back pain with leg pain. Okay. Not there. You can consider the use of dry needling in conjunction with other treatments and disability with chronic low back pain. So not so much from a manual therapy standpoint for the acute with leg pain. They're more kind of the acute back pain or chronic back pain with leg pain, not so much with the acute leg pain. All right, so if we can kind of just imagine that's the document that we're going off of. And then if we said, well, we're trying to use things to treat the acute back pain with leg pain. We've got manual therapy, we've got directional preference activities, we've got exercise stabilization, and then we've got some things that are a little bit lower quality, like dry needling, traction, and then of course you've got medical management, right? You've got your medications, you've got your epidural steroids and so forth. And so I find that a combination of those things, just like Chase and just like Jason were saying, a combination of those things based on tolerance is helpful. Lumbar radiculopathy is probably one of those that's a little bit more of a mixed bag in my experience because there's such varied presentations in how acute and how things tolerated, also people's perceptions of pain. And so you really have to be on your toes sometimes to kind of get a treatment started and get the patient to buy into those treatments. I think if we can get them feeling a little bit better, so maybe we use positional treatments to open up the foramen, maybe give the nerve root a little bit of rest or relief, or maybe we use some dry needling, maybe we use some hands-on touch initially, some of those things. Even if they're not high quality evidence, they can give the patient a little bit of buy-in and then they can start to kind of feel a little bit better, right? And so that's why I call it kind of a mixed bag. But if we keep going, if we keep looking at things, the next classification would be a somatic referral. You could also call this a segmental dysfunction. This is one where there's none of that referral pain below the knee. It typically stays above the knee, and so we'll see pain in the buttock or the thigh or the low back. It's generally after a particular movement. Maybe I bent over, maybe I tried to lift something and I felt kind of this little click. It's typically something that is deep, achy, but rarely goes below the knee. And so you can imagine one of the questions that you might ask somebody initially on an evaluation, right, would be, you've got this pain. Does it ever seem to kind of travel below the knee? And that maybe help you kind of put somebody in one category versus another early on. And as you keep going, you're going to kind of find pieces that help either confirm that or refute it. You typically have a little bit of stiffness with the pain being provoked by either kind of a movement at end range, but it's usually predictable. It's like every time I go to the left, I get this pain. It's kind of a deep, achy discomfort, but it doesn't shoot down my leg. It's just kind of always right there. Or every time I bend forward mid-range, I get a little bit of kind of pain there. And so some of the things we can use to kind of help categorize this person might be maybe our PIVMs or our UPAs, CPAs. We might be able to get a little bit of kind of reproduction with active range, passive range, and then also screening the joints above and below, and then kind of making sure that that neuro screen is clear. We're not seeing any changes in strength, reflexes side to side. And so you could then kind of go through the same exercise on what interventions do you currently use, or we can start to kind of provide some of the evidence already and just go through that. Have you heard of the Flynn rule? Anybody heard of that one? It's the article written by Flynn that talks about who's going to respond to manipulation. Okay. So our category here is somatic referral. Maybe a secondary category might be segmental dysfunction. And so we're thinking that this person has non-radicular low back pain, so it's somatic. It's been present for 16 days or less. There's no symptoms distal to the knee, which helps us kind of again say it's not radicular. They've got a low fear score, FABQ work score of less than 19. They've got good hip internal rotation, so the hip screen is negative, basically. Hip internal rotation, if you recall, just screening hips in general, internal rotation is the one that you lose the most and usually first. So as long as they've got good hip range of motion, their screen is clear, and then you find through your assessment, your CPAs, your UPAs, your PIVMs or PAVMs, that they have a segment that is either stiff, stuck, or can reproduce their symptoms. This person is likely going to benefit from thrust manipulation of the lower back. And what you see on the right side of there, that if you meet at least four of those, you've got a pretty good 95% and a high likelihood that this person is going to have a successful outcome if you use lumbar manipulation. And honestly, even 3 out of 5 is pretty good. So if you wanted to just briefly, show of hands, anybody use lumbar manipulation? Okay, I can see Jack, good. I got a lot of cameras off, so hard to see hands. But if you're using lumbar manipulation, how are you deciding that you want to use it? Are you putting somebody in a category? Are you using evidence behind it? Or you're just like, hey, this person doesn't have pain below the knee. I think I'll use this. Jack, I'm going to pick on you because you raised your hand. I appreciate you being involved. What do you think?
Usually I see if it's one segment that's hypomobile, I do check to see if it's below the hip or not. But if there's one segment that's very hypomobile and I just can't, a UPA doesn't do it, then I'll try to manipulate it and see if it loosens up a little bit.
Good. Just a follow-up question. Where did you learn your lumbar manipulations?
Um, ISPI, International Spine and Pain Institute, from the Australian guys.
Yep. Okay. So you didn't learn it in school.
They touched on it, but I didn't feel
Yeah.
very comfortable.
Right. Right. That's the same with me. In school, I mean, back in the 90s, we didn't really do any manipulations. So I had to take all of mine outside manual therapy residency and then additional courses, just like you're saying. So um, those will be some of the things that if you're looking for Con Ed, I think those are good places to start. So appreciate that, Jack. Thank you. All right, keep rolling. Movement coordination impairments is kind of our third classification. It's a motor control deficit, poor lumbar control. You'll see a lot of these people with recurrent episodes of back pain. They are typically younger, in their teens, 20s. They could have had an initial episode, and then now in their 20s, 30s, and even up into their 40s, they've just had recurrent back pain. It would come, go. It might stick around for a week or 10 days, but then it goes away, and now it's back. And this time it's lasted a little bit longer, so they decided to go to the doctor, right? They get x-rays. X-rays are typically pretty clean. They might show a little early degeneration, but I mean, these people are in their 30s, 40s, so there's not going to be a whole lot unless it's pretty significant. All right, so the recurrent episodes, they've got aberrant movement patterns or abnormal movement patterns where maybe there's a painful arc as they're going through flexion, kind of in that mid range or at that initial um, kind of moment where lumbar spine starts to move. They'll get this catch. If they can continue going through it, a lot of times you'll see them using their hands to kind of climb back up their thighs, what we call the Gower sign. But in general, they've got poor lumbar control. If they're going through flexion and extension just for your screening, they have a hard time kind of stopping at neutral. Sometimes they'll overshoot it and come back. Or if they go side bending, they'll have a hard time. Sometimes they'll come back, they'll overshoot that neutral. So really just kind of poor movement control, poor proprioceptive ability. They're typically provoked by sustained postures, standing, standing at that desk, standing on one leg at that desk. I'm picking on some of my folks that I work with. That they'll tend to stand on one leg and kind of shift all their weight over to one side, right? And then it's like my back hurts and I'm not really sure why. Or I move and I feel better. Okay, so you'll hear them say that I move and I feel better. I don't feel so good whenever I sit or stand for a long period of time. So that mid-range loading is then eased by movement, position changes. They'll have some referral. It'll be local. So if it's kind of mid lumbar, it'll refer to the buttock, maybe posterior thigh, maybe kind of gluteal crease, but it really doesn't ever get into the lower extremities. It's all kind of that somatic kind of referral there. Some of the tests that we can use, we've got prone instability test. We've got passive extension test where you take the feet when they're in prone and just kind of gently lift the legs up about 6 or 8 inches, and you'll put an extension moment pressure into their lower back. And the patient will generally complain that, hey, my back feels real heavy. I don't like the way that feels. That's the kind of passive extension test. Segmental hypermobility in feel. So Jack a minute ago mentioned I might find a segment that feels really stiff. In this instance, you're going to find one that feels really kind of loose, or it doesn't have quite the end feel that the other one did. It might even be provocative as you're doing your CPA, which would be the first half of that prone instability test, right? At that point, you'd have them lift the legs up, you retest that and see if it feels better. And that would be then the positive if it does decrease their pain. And so at this point, you could say, well, what interventions do we use? And let's see here. I've got Leander. Leander, we've got somebody that we think has some lumbar instability. We've got movement coordination impairments. What are we going to use with these folks? What do you think?
I would start with something more basic, like just bracing at first with breathing, encouraging a full deep breath so they're not stabilizing through the lungs. And then work on some rotational stabilization, like some walkouts or pal-off presses, and then just kind of progress them up from there, depending on symptoms and how they're tolerating everything.
Okay, very good. Appreciate that. Do you have follow-up question for you? Do you have any sort of grading scale for your lumbar kind of exercises? Like, do you have like this person's a level 1, this person's a level 3? Do you have any kind of a grading scale for that?
I do kind of have my own like personal one with like dead bugs. And so
Okay.
a lot of it is based off of how they're tolerating like just bracing and maintaining a breath pattern. If they can't do a full dead bug without pain, then I usually don't progress them up from there. And I just, depending on, sometimes I have to modify it where feet are down or supported, or we have to facilitate more with bands or something like that.
Okay, great. So I think that is fairly common. Anybody else want to kind of jump in on this kind of lumbar stabilization scale? I see Colby's there. I see Matt there. I've already picked on Jack. I've got, oh, Jeremy's watching. Wow. Jeremy, you got any kind of a lumbar stabilization scale that you're familiar with?
Very similar to what was just said, but also for a while at Carroll, we had a uh, graded scale of entry level stabilization exercises on table that progressed to um, obviously higher level on the table than off the table from there. So some of it is, I guess, experience based, some of it is based out of literature. So it's kind of pulled from different directions. Um, but it seemed to be fairly consistent with as you integrate it into programs. You had to modify it. I mean, some of the athletes,
Sure.
that's easy to challenge your athletes, but you had to modify it for some other populations.
Yeah. And if I recall, you guys actually made kind of a handout or a thing that the doctors would give out to the patients, and we used that. I used that. I still use that today, and it might be something that we can do another grand rounds on. Is that kind of Watkins scale or that lumbar stabilization protocol that you guys put together?
Chase had a comment there on the
Let's see if I can go back up and get. Oh, the Sarnan progressions. Yep. Yeah, for sure. All right. Very nice. So who responds then? How do we make the decision on actually who's going to respond? Very similar to the um, lumbar manipulation criteria. We've got some criteria here that were put together. If we've got an age less than 40, okay, so that fits into most of our demographics. We said they're kind of in their 20s, 30s, 40s. They've got a straight leg raise of at least 90 degrees. This article here says greater than 91, kind of indicates maybe a little hyper flexibility. They've got an aberrant movement pattern or an abnormal movement pattern. This responds or this is indicated or seen in kind of flexion and then return from flexion. If you've ever seen somebody, hopefully everybody is kind of watching skin. You're raising t-shirt, you're watching skin. As they go into flexion, you'll see this as kind of a juddering or kind of a cogwheel movement through that mid-range of flexion. And they also then may have this prone, positive prone instability test. And so if we've got at least 3 out of 4 of these, it's almost 2/3 of the people are going to be successful with a stabilization program. So again, here you've got some evidence behind your decision making and your categorization. So if we take all three of these categories, kind of put them up here together, now we start to see kind of some of the differentials for this: radiculopathy, somatic referral, movement coordination impairments. Radiculopathy, obviously, we've got the leg pain. Maybe they have a little directional preference. All the way across the screen to the right, you've got the somatic referral and so forth. Some of the key tests are listed there for you. First line treatment, I think, is something that kind of most of us are interested in. What am I going to start to do with this person? And then what's the evidence help support? Okay. So just a kind of a quick little slide for you. So practical, what are you going to do? How are you going to use this information tomorrow in the clinic? We're going to, obviously, you're going to do our subjective kind of interview, screen out for red flags. We're then going to look for these exam pieces that help us understand, do they have a directional preference? Are they kind of showing us some positive neurodynamic problems with slump test or leg raise and so forth? Or do we have a segmental mobility problem? Is it hypo? Is it hyper? And then we're going to move into this classification piece, and we're going to try to match those impairments to one of these three categories so that we can then kind of have the evidence behind us on our treatments that are linked to that classification. And then when we go back and reassess, we can reclassify as we need. It's not to say that classification is a one-time thing. You can't have somebody in more than one classification at a time, right? You can have somebody in a hypomobility or a hypomobile kind of piece where they've got mobility deficits as their classification. And if you manipulate that deficit, free it up, now all of a sudden you reassess and they've got some motor control issues. Maybe they move into a movement coordination classification, and I'm going to start to do some stabilization exercises with them. Maybe if you're a little bit more experienced clinician, this kind of sounds like, well, that's what I do already. And that's great, because all this is doing is showing you that what you're doing is based on experience, and now the evidence is coming along to kind of show that to you. Whereas if maybe you don't have as much experience, this can kind of help you understand, well, this might be something that is going to be helpful for me to kind of get this patient moving along in the right direction. All right. So again, that was just kind of our cheat sheet there. If we look at kind of, again, just what evidence is telling us, I've made some quick little kind of pieces that you can print off. We've got acute low back pain with leg pain. We've got chronic back pain, been present for 3 months or more. Chronic back pain with leg pain. That might be maybe your stenosis person. Maybe they're a little bit older and so forth. Maybe you've got somebody with movement control impairments, older adults, chronic back pain. They're all kind of listed there for you. This is the kind of sheet that if you look for manual and other directed therapies, here is kind of our population on the left side, the grade, and then kind of the recommendation that the evidence is providing for us. So this is, again, a summary sheet. You can kind of maybe print some of these off if you wanted to. So our classifications. This helps to support what I said earlier about radiculopathy being kind of a mixed bag. When you've got acute low back pain, classification systems are a little tough because they can have features or symptoms of multiple classifications. And so you can use them, but they're a little tough as opposed to some of the other low back pain kind of staged pains that we may get. And then education. as a recommendation. It's got A and B across the spectrum, so education is always helpful. All righty. We kind of talked through these as we went, as we did our presentation. And I asked Jack specifically, I said, how did you get involved in manipulation? And that kind of answers that question for if there's a barrier for you in feeling comfortable with manipulation, that can be something that we seek out as a company is to build a manipulation class. Or we can start to seek out additional CEUs as individuals. But manipulation is certainly something that can be helpful. So if you're interested in it, look for a clinician that uses manipulation, talk with them, spend a little bit of time learning from them as well. All right. Just kind of trying to wrap things up here for us. If we look at classification by behavior versus imaging, I think you end up with a little bit more of a cohesive treatment plan as opposed to saying you've got degenerative disc disease. Here's a handout. I'll see you next week, kind of thing. I don't think any of us really do that, but those clinics are out there, and you probably know of one or even maybe worked in one. So try to classify behavior by symptoms, by those things that they're telling us versus what the doctor has told them, the imaging and so on. The prediction rules add confidence to us. They give us help by kind of showing us what the evidence says, and that can then help us with that patient relationship, bringing the evidence in and saying, look, this piece of literature is telling me that what we're doing is going to help. If it doesn't, then we can get some additional help with referral back to the doctor. We can start with medical management and so forth. Okay, so if you go down the roads and it's not helping, then at least you know I've done everything I can, everything I should to make this better. And at some point, maybe we need additional help. And that's really where the reassessment comes in. Reassess relentlessly, always trying to look and see, do I need to maybe move classifications or do I need to send them back to the doctor because they're honestly getting worse? All righty, there's our references, and there is a quick reference for kind of most everything that we've talked about. So I will share this presentation with whoever emails me. So just kind of shoot me an email if you want to have a copy of that presentation. More than happy to share it. The recording here will go up on our YouTube channel. And will be available for view if somebody missed it or if you want to go back and review it. Or if you just want to make fun of all of my uncomfortable pauses during the presentation, that's fine too. You can do that. Let me open it up for questions. If there are any questions, we can spend a few minutes here. I think we've got about 10 minutes before the top of the hour. So if we've got any questions, we can do that. Janelle, y'all good? All right. Okay, Quarry Lake's good. Nice. Okay, folks. Well, no questions. I appreciate your time. We will do this again next month. Honestly, can't remember what the topic's going to be, but hang tight. We'll get that out to you. And have a good rest of the week. Thanks for joining us.
Thanks,
Thanks,
James.
James.
Thanks, James.
Thank you, James.
Y'all have a good afternoon.